we're going to go ahead and get started, everyone. I believe our first presenter is Miss Nareena Imam from Rutgers Robert Wood Johnson School of Medicine. And this project is entitled Nephron Sparing Surgery Outcomes in Wilms Tumor. Is it ready for prime time?
Hi, my name is Nareena Imam. I'm a fourth-year medical student at Rutgers Robert Wood Johnson Medical School, and I did this project under the direction of Dr. Burjan Rapa. I'm going to be talking today about the use of nephron sparing surgery in unilateral Wilms tumor. So the overall survival for Wilms tumor patients is close to 90% with the combination therapy of surgical resection, chemotherapy, and/or radiotherapy. The current gold standard surgical treatment is radical nephrectomy, either before or after chemotherapy and radiotherapy, depending on stage. Advances in adjuvant therapies have fueled the growth of organ-sparing surgery, which has the goal of maintaining native form and function while preserving equivalent oncologic outcomes. This has already seen success in breast, lung, and urologic malignancies in adults. In the kidney, nephron sparing surgery is currently indicated for bilateral Wilms tumor and disease involving a solitary kidney. 65% of adults who were treated with nephron sparing surgery for various renal pathologies developed moderate renal dysfunction, defined as a GFR of less than 60, compared to 85% of patients with radical nephrectomy over the course of 10 years. This has recently inspired the use of nephron sparing surgery for unilateral Wilms tumor. However, few studies have quantified the efficacy and safety of nephron sparing surgery for unilateral Wilms tumor on a population-wide scale. Thus, the purpose of our study was to use a large national registry to investigate outcomes of nephron sparing surgery for unilateral Wilms tumor. Our hypothesis was that the outcomes of nephron sparing surgery for unilateral Wilms tumor would be non-inferior to the current gold standard treatment, which is radical nephrectomy. The database we queried was the NCI's SEER database for pediatric patients who were diagnosed with Wilms tumor between the years 2000 and 2018 and were treated with nephron sparing surgery or radical nephrectomy. Our goal was to generate survival curves using log rank analysis and plot them with Kaplan-Meier curves. We identified 1,087 Wilms tumor patients who were treated with either nephron sparing surgery or radical nephrectomy. 69 of these patients we excluded due to a lack of surgical classification, leaving us with 1,018 patients remaining. Of these, 945 were treated with radical nephrectomy, and 73 were treated with nephron sparing surgery. 3 of the nephron sparing surgery patients were excluded due to a non-renal origin of tumor, and 33 of the patients who were treated with radical nephrectomy were excluded as they were duplicates. That left us with a final cohort of 912 radical nephrectomy patients and 70 patients who were treated with nephron sparing surgery, 45 of whom were treated with unilateral disease and 25 of whom were treated with bilateral disease. We found that patients with bilateral disease tended to be younger, but there was no significant difference between gender or race and unilateral or bilateral disease. In patients with bilateral and unilateral disease, they had similar tumor size, and no differences were found between radiation use, chemotherapy use, and positive regional lymph node status between bilateral and unilateral nephron sparing surgery. In terms of cancer-specific survival, that was not significantly different between unilateral and bilateral nephron sparing surgery. When we stratified by stage, patients with local or regional disease had no significant difference in cancer-specific survival between unilateral and bilateral nephron sparing surgery. Similarly, in patients who had distant disease, there was no significant difference in patients undergoing unilateral or bilateral nephron sparing surgery. When we compared them to a cohort of radical nephrectomy patients, there was no significant difference in cancer-specific survival in patients who underwent radical nephrectomy, unilateral nephron sparing surgery, or bilateral nephron sparing surgery. There were quite a few limitations to this study. First, that it was a retrospective study, so we were unable to determine true causality. Secondly, there was a lack of comparable staging data available in the SEER database, which classifies stage in local, regional, and distant disease, which doesn't directly correspond to the traditional stages 1 through 5 for Wilms tumor. Further, there was no comorbidity data available, and we were unable to identify those patients who may have had disease in a solitary kidney. In conclusion, survival outcomes for unilateral nephron sparing surgery, bilateral nephron sparing surgery, and radical nephrectomy were equivalent. So unilateral nephron sparing surgery can be used safely in disease of any stage. As the overall survival for Wilms tumor patients approaches 90%, goals of care have shifted to limit complications and improve renal function in these patients. Studies have shown that nephron sparing surgery improves renal preservation in these patients compared to radical nephrectomy for unilateral disease. And future studies should be prospective and look at specific renal functional outcomes and long-term oncologic outcomes in these patients. I have no disclosures to report, and thank you so much for having me here.
This abstract now open for discussion.
Juan Gurria from Cincinnati. Thanks for the talk. I was wondering if you have any data on who are those patients that received nephron sparing. Did they have any correlation with syndromic Wilms?
So thank you so much for your question. That was significantly one of the limitations of our study, was that there was no comorbidity data available in the database, so we were unable to determine whether or not they may have had any syndromes like Denny-Strace or Wagner syndrome.
Hi, Richard Glick from New York. I'm just wondering about the issue of the amount of chemotherapy, positive margins, radiation therapy, et cetera, in these patients for unilateral nephron sparing. Can you comment on that?
Yeah, that was data that was, thank you so much for your question. That was also data that was not available in the database. We were able to determine which patients had chemotherapy and radiation therapy, but we were also not able to determine patients who had it before or after surgical resection.
So the issue of the syndromic patient is very important because those would be patients that are surveilled and have small tumors. The issue here in the United States, as opposed to Europe, is our patients don't get preoperative chemotherapy. Typical Wilms tumor unilateral is very, very large, which would not be able to be amenable to nephron sparing surgery. You know, there are limitations, like you say, to your database, but it was important. It was an important study. Thank you.
Thank you so much.
From Northwestern, thanks for this study. I would mostly echo what Richard was saying. I think you just have to be very careful with the interpretation of this, because almost certainly almost all of those patients who had nephron sparing surgery had either bilateral disease or some known predisposition syndrome. And so this technique is being employed in a very selected group of patients who were probably surveyed or surveilled, and I just would be cautious about recommending it for a broader population.
Thank you so much.
I was also curious to know, did you have any, you talked about tumor size, but did you have any other information about tumor location? Was the nephron sparing approach more likely to be used for left-sided tumors or right-sided, upper pole, lower pole, those sort of things?
Thank you so much. Unfortunately, I didn't look at that information.
Well, great job. Thank you.
Thank you. Thank you for having me.
And our next presenter will be Dr. Richard Geyer from Massachusetts General Hospital. And the presentation is entitled Neuroblastoma Cells Include Heterogeneous Populations of Highly Plastic Quiescent and Proliferative Cells Marked by CD49B Expression.
Thank you all very much for the chance to present this work here in this forum. How do I advance the slides?
Use the mouse.
It's not clicking. Oh, there we go. We have no disclosures to report. Recent high-profile papers have utilized single-cell sequencing technology to define developmental hierarchies of neural crest-derived cells, including cells of the adrenal medulla and other sympathetic neurons. These studies have shown that Schwann cell precursors, which express many of the same genes as glial cells, are the progenitors for peripheral sympathoblasts and sympathetic neurons. Neuroblastoma occurs when normal differentiation of the neural crest-derived Schwann cell precursors into sympathetic neurons is disrupted. Two predominant cell states have also been defined among neuroblastoma tumor cells. One is a mesenchymal state, which includes immature cells that are highly proliferative. The other is a more mature adrenergic cell state that fairly closely resembles differentiated neurons and is less proliferative. CD49B is a cell surface antigen that denotes immature neuronal precursors in glial cells in other developmental contexts. We thus hypothesized that differential CD49B expression distinguishes these two neuroblastoma cell states, and that neuroblastoma cells can interconvert between states. Although we have performed these experiments with several neuroblastoma cell lines, all the data I'm showing on my slides here today was generated using the mouse Neuro2A cell line. We used flow cytometry to analyze CD49B expression on Neuro2A cells and found heterogeneous expression of the antigen. This hints at the possibility that CD49B expression may mark distinct populations among heterogeneous tumor cells. We also used cytometry to analyze cell cycle status. When we analyzed the highest, lowest, and middle 25% of cells based on CD49B antigen expression, we saw a clear trend of greater proliferation among cells that express the antigen highly, providing further evidence for biological heterogeneity. To confirm that CD49B differentiates tumor cells in distinct biologic states, we performed RNA sequencing after sorting the cells into the top and bottom quartiles of CD49B antigen expression. We found thousands of differentially expressed genes, far more than we anticipated, confirming that CD49B distinguishes biologically disparate cell states. We also noted that many of the genes are specific to CD49B low cells, which I've highlighted here in the red box, are known neuronal marker genes. To visualize this in a different way, I'm showing here a heat map of canonical neuronal marker genes known from the literature, nearly all of which are more abundant in CD49B low cells. This demonstrates that CD49B low cells have a gene expression program more like differentiated neurons. We've also found that CD49B low cells can generate CD49B high cells in culture. If we sort the cells with the lowest CD49B expression, return these cells to culture, and then reanalyze for 7 days, we see cells with the full range of the CD49B antigen expression in our cultures. This result demonstrates that tumor cells with a gene expression program similar to differentiated neurons have an inappropriate ability to de-differentiate to a less mature cell state. Now, the set of genes a cell expresses at any given time is determined by the genomic enhancer elements that a cell has activated. Active enhancers are marked by acetylation of lysine 27 on histone 3. A different histone modification, monomethylation of lysine 4 on histone 3, can be used to identify enhancers that are primed but not yet activated. We profile lysine 27 acetylation by cut and run to identify enhancers that are specifically active only in CD49B high cells. Unsurprisingly, CD49B low cells display very little of the active mark at these enhancers, as seen in the heat map and accompanying profile plot on the right-hand side of the slide. However, in contrast to what would be expected in a normal developmental hierarchy, CD49B low cells maintain the priming mark of monomethylation on lysine 4 at CD49B high specific enhancers. This result shows that despite adopting a more differentiated gene expression program, these tumor cells maintain epigenetic potential to de-differentiate. In summary, we believe that neuroblastoma's tumor cells can spontaneously interconvert between a mature neuron-like state and a less differentiated, more proliferative state. We believe that failure to decommission enhancers and maintenance of priming marks is likely a mechanism underlying this cell phenotype plasticity. We believe that such phenotypic plasticity, permitted by epigenetic deregulation, may be a fundamental trait of neuroblastoma cells and may underlie relapse response following therapy. I want to thank other members of our laboratory for their help with this project, and particularly acknowledge Alan for allowing me to pursue a project which was a bit out of the traditional trajectory of our laboratory. And also acknowledge our funding sources internally from MGH and from the National Institutes of Health. I'd be happy to take any questions.
Hi, Andrew Murphy from Memphis, Tennessee. Those are great presentation. I wondered how the CD49 status of the cells might change in response to treatment, and whether a CD49 based signature could be related to treatment resistance or not.
That's a good question. We've done some sort of preliminary studies in that regard, and it seems that the CD49B high cells are more sensitive to, the only agent we've tested is cyclophosphamide, a little more sensitive in culture to that. And there is obviously historic literature, I'm sure a lot of you are aware of, that therapy can induce histologic maturation of tumors. which I would suspect means the more CD49B low cells than high cells is associated with that histologic maturation, but we and others have not looked at that, so.
Thank you.
Road Mariotti at UAB GenSurg. Echoing Dr. Murphy's question, rexinoids and retinoids have been used in neuroblastoma treatment, especially for high-risk neuroblastoma. Have you looked at your marker in relation to retinoids treatment, and do you see it kind of like, would you think of it in the future clinical application being a marker of dedifferentiated cells, and how does that relate to treatment?
Yeah, I think that high CD49B expression probably is a marker of less differentiated, less mature cells. A lot of these cell lines, as you probably know, can be differentiated to something that sort of resembles a mature neuron in culture, and retinoic acid is often part of those protocols. We haven't really pursued that, at least so far, but it's an interesting question, I think.
Thank you very much.
Thank you.
Good job.
Next up, we have Dr. Jillian Jacobson presenting combination BET and PARP inhibition synergistically inhibits tumor cell growth in neuroblastoma in vitro.
Thank you for the opportunity to present our work. Bromo and extra-terminal domain proteins are regulators of transcription that play vital roles in cell cycle progression, DNA repair, and cell survival. BET inhibitors, such as JQ1, function as epigenetic modifiers, and in preclinical models of neuroblastoma have been found to downregulate MECN expression, induce differentiation, and cause apoptosis. However, clinical testing and application of BET inhibitors in other cancer types has been inhibited by unexpected dose-limiting toxicities. PARP inhibitors, including olaparib, have been FDA approved for the treatment of several adult cancers, such as breast cancer and pancreatic cancer. PARP inhibitors prevent PARylation and trap PARP onto DNA, converting single-strand DNA breaks to double-strand breaks and increasing cells' dependence on DNA repair pathways such as homologous recombination. However, despite recent studies showing that high PARP expression is associated with poor prognosis in neuroblastoma, most current studies have focused on the use of PARP inhibitors in cancer types with known deficiencies in homologous recombination. There's an urgent need to develop novel treatment strategies for the management of neuroblastoma. We hypothesize that the BET inhibitor JQ1 would promote a DNA repair deficient phenotype, sensitizing neuroblastoma cells to PARP inhibition by olaparib. We use 3 human neuroblastoma cell lines, the MECN-amplifying BE2C and IMR32 cell lines, and the non-MECN-amplifying SKNSH. We had 4 treatment groups: control, JQ1 alone, olaparib alone, and combination. And we use CCK8 assays and clonogenic assays to evaluate for changes in cellular proliferation after treatment, as well as microscopy to evaluate for changes in cellular morphology, and immunoblotting to evaluate for changes in protein expression. We found that combination treatment with JQ1 and olaparib decreases the IC50 of JQ1, and that's regardless of MECN amplification status. However, the optimal timing of treatment may vary by MECN amplification status and cell line. As you can see here, treatment with olaparib decreased the IC50 of JQ1 by 12.1, 19.9, and 2-folds in the SKNSH, BE2C, and IMR32 cell lines, respectively. However, staggering treatment of olaparib 24 hours after treatment with JQ1 significantly decreased the IC50 of JQ1 by 51.3 folds in the non-MECN amplifying SKNSH cell line, whereas in the MECN amplifying BE2C cell line, it actually increased the IC50 of JQ1, and that may reflect the rapid doubling time of the BE2C cell line. We also found that combination treatment inhibits colony formation in vitro, such that combination treatment decreased colony formation by 43% in both the SKNSH and BE2C cell lines relative to control. We also found that colony formation is inhibited in a dose-dependent manner, such that increasing doses of JQ1 and increasing doses of olaparib are both sufficient to decrease colony formation in vitro. However, it's the combination of JQ1 and olaparib that was most effective at decreasing colony formation, with higher doses of JQ1 and higher doses of olaparib being most effective at decreasing colony formation. We also use microscopy to evaluate for changes in cellular morphology after treatment, and found that combination treatment-induced differentiation, as shown by neurite outgrowth in both MYC-N amplifying and non-MYC-N amplifying cell lines, as shown here. We also found that in MYC-N amplifying cell lines BE2C and IMR32, combination treatment induced an increased protein expression of P53, whereas in the non-MYC-N amplifying cell line, there was an increase in P21 protein expression. And these results have been the source of further experiments in the submission of this abstract evaluating for a possible mechanism of action behind the efficacy of this treatment combination. In conclusion, combination BET and PARP inhibition may provide a novel strategy for treating neuroblastoma. And because PARP inhibitors are already FDA approved for other cancers, this would allow for a more rapid translation of this treatment strategy for neuroblastoma. BET inhibition sensitizes neuroblastoma cells to PARP inhibition, decreasing cell viability and promoting differentiation of neuroblastoma cells in vitro. However, the optimal timing of treatment may differ by MYC-N amplification status and cell line. Further studies are needed to elucidate the mechanism of action behind combination BET and PARP inhibition's efficacy against neuroblastoma. I'd like to thank the following members of my lab, and I'm happy to take any questions.
For discussion, if there's any questions. I had a question. When you gave the combination or the staggering therapy, what was the difference in time points between the two introductions of the medication?
Sure. So in the first iteration of the experiments, I treated both drugs at the same time, and then to calculate the IC50 72 hours after. When I staggered, I would plate the drugs, allow them to attach overnight, treat with JQ1, and then exactly 24 hours later treat with olaparib, and then calculate the IC50 72 hours after completing the combination.
Laura Stathman, I'm a fellow at Vanderbilt. I was just wondering if you look to see if you were thinking these two drugs are acting together in an additive manner, or if you think they're acting synergistically, and if you could comment on why you think that, if you do think they're acting synergistically, that may be happening.
Sure. So the reason why I actually did the staggering was to look for that synergism, and so I think that may reflect in the BE2C cell line. I think because of the rapid doubling time, that cell line in particular had the chance to overcome the single drug treatment. And so I do think there is some synergism there, but I think, as by shown with the clonogenic assays, there's definitely an additive effect between the two drugs. The problem with BET inhibitors in current clinical trials, most clinical trials focused on hematologic malignancies, but they've been having issues with dose-limiting toxicities, namely thrombocytopenia. And so I actually studied numerous other adult cancer types, and that's how I found olaparib, which has not really been studied in neuroblastoma. There's one major study. But I found that the BET inhibitors, because their issue is the dose-limiting toxicities, that I may be able to overcome that with the PARP inhibitors. The problem with the PARP inhibitors is that they rely on defects in homologous recombination. And while I don't go into the mechanism here for this abstract, the BET inhibitors downregulate the expression of DNA repair proteins, which increases the sensitivity to the PARP inhibitors. And that's how I think it's working in the MYC-N amplifying cells specifically.
Thank you so much.
Thank you.
Next, we have Dr. Rachael Clark from UT Southwestern presenting SHMT2 inhibition induces differentiation in high-risk neuroblastoma cells.
Good morning, and thank you for this opportunity to present my work. Oh, here we go. Thanks. I have nothing to disclose. High-risk neuroblastoma remains the most difficult to treat, with an overall survival of less than 50%. High-risk neuroblastoma is associated with MYC-N gene amplification. It has been shown that MYC-N silencing induces differentiation in neuroblastoma cells. In addition, mitochondrial 1-carbon metabolism is affected in a MYC-dependent manner by serine hydroxymethyltransferase 2, also known as SHMT2. SHMT2 is a mitochondrial enzyme important for the conversion of serine to glycine, and SHMT2 is upregulated in several cancer types. Its expression is associated with tumor aggressiveness and prognosis in several cancers, including glioma and breast cancer. And we have previously shown that MYC-N amplification is associated with SHMT2 expression in neuroblastoma patients, and that SHMT2 silencing impairs cellular proliferation, migration, and colony formation of neuroblastoma cells in vitro. SHIN1 is a novel SHMT2 inhibitor developed out of Princeton that is being used in preclinical studies to treat cancers such as leukemia and lymphoma. We have previously shown that SHIN1 inhibits neuroblastoma cellular proliferation in vitro. Here you can see the IC50 curves of SHIN1 with 4 different neuroblastoma cell lines. So because we know that SHMT2 silencing decreases MYC-N expression and that MYC-N silencing induces differentiation in neuroblastoma cells, we hypothesize that inhibition of SHMT2 with SHIN1 will induce differentiation in neuroblastoma cells. To further evaluate this, the SKN-SH cell line was used. Cells were plated and treated with 6.4 micromoles of SHIN1 or control medium for 24 hours. Representative images were obtained and immunoblotting was performed to assess for protein markers of differentiation, including neuron-specific enolase, or NSE, synaptophysin, and GAP43. As you can see here, SHIN1 successfully induced differentiation in the SH cells after 24 hours. On the left, you can see the control cells, and the right, you can see the marked neurite outgrowth indicating differentiation. In addition, treatment with SHIN1 increased the protein expression of differentiation markers, including NSE, synaptophysin, and GAP43. Treatment with SHIN1 increased NSE by 1.5-fold, synaptophysin by 1.3-fold, and GAP43 by 1.9-fold. In conclusion, inhibition of SHMT2 with SHIN1 impairs cellular proliferation and induces differentiation in vitro. Further studies are needed to evaluate the mechanism behind SHIN1-induced differentiation and the effectiveness of SHIN1 in vivo. The use of SHIN1 alone or in combination may serve as a novel therapeutic strategy in high-risk neuroblastoma. I want to thank my lab members for their assistance, and I will take any questions.
What's your next step?
So I've actually started using a different SHMT2 inhibitor, SHIN2. It's from the same lab at Princeton. It has a higher specificity for human SHMT2. And I'm investigating the different mechanisms behind the differentiation. So I've been looking at the effects on some genes that are responsible for dedifferentiation. So seeing the effects of the mRNA expression after SHIN2 treatment, and I've seen that the treatment decreases the mRNA expression of the dedifferentiation genes. I'm also doing some functional studies to see if the SHMT2 inhibition translates to cell functions such as proliferation, colony formation, wound formation, and it has shown some success as well.
Juan Gurria, Cincinnati. Have you guys combined your techniques with Dr. Strong's lab?
We definitely work together. She definitely takes better pictures though of her neurites, so I gotta get on that.
I was going to ask, have you replicated these studies in the other cell lines that were discussed?
Yeah, I have. For brevity, I only included one, and the SH cells had the best representative increase in the neurite outgrowth, but I've done it in 4 other cell lines, including MYC-N and non-MYC-N amplified cell lines as well.
Thank you so much.
Thank you.
The next presenter will be Dr. Laura Bownes from the University of Alabama at Birmingham. She'll be presenting on the topic Novel Protein Phosphatase 2A Activators Decrease the Malignant Phenotype in Neuroblastoma Cell Lines.
Awesome. All right, good morning, everybody. Thank you all for the opportunity to share our work today. I want to join the club and clearly have issues advancing the slide. Sorry. The green button. Oh, this guy. Okay, sorry, guys. Here are our disclosures. So, as y'all have heard frequently this morning, despite medical advancements, the five-year event-free survival rate for high-risk neuroblastoma remains dismal at 50% in children with this disease, as shown here by the bottom blue line from the COG. Therefore, it's crucial to investigate possible therapeutics for this patient population. So protein phosphatase 2A, or PP2A, is a phosphatase which functions as a tumor suppressor, and our lab has previously shown that it is suppressed in neuroblastoma. So because of our lab's prior findings, we wish to investigate novel compounds that keep PP2A activated. So ATUX 3364 and ATUX 8385 are two of these novel activators. So we utilized two neuroblastoma cell lines, SHEP and WAC, and we performed an activation assay, and we found that treatment with either of these compounds successfully activated PP2A. So we next investigated viability in 4 long-term passage neuroblastoma cell lines using a colorimetric assay, Almar Blue, where we treat the cells at increasing doses for 24 hours. And we found that viability was decreased in all the cell lines following increasing doses of 3364 treatment. And we performed a similar experiment with increasing doses of 8385 in the 4 cell lines as shown to the right, and we found similar results with a significant decrease in viability. We also examined these compounds in a neuroblastoma patient-derived xenograft, PDX6, that was previously established at our institution, and we found that treatment with increasing doses of either compound significantly decreased viability in the PDX cells. So we next assess cell migration using a scratch or wound healing assay. So in this assay, we make a scratch in a monolayer of cells in the shape of a cross in order to create an open wound area, which here is highlighted in black. So we watch the cells close the wound over time, and we can measure the remaining open area. So we performed these experiments in 2 cell lines, the SKN-BE2 and SHEP cells, and we found that treatment with both 3364, shown by the green line, or 8385, shown in gray, resulted in significantly decreased ability for the cells to close the wound over time, suggesting decreased motility. So we examined invasion in the PDX cells using modified Boyden chambers. So we plate these cells into the inserts where we have an added layer of matrigel at the top of the insert that simulates a sort of extracellular matrix that then the cells have to invade through in addition to the bottom membrane of the insert. So then after 1 week, we can stain the cells that were able to invade successfully and quantify the cells. So this is a representative picture of the untreated cells that were successfully able to invade that are highlighted here by these red arrows. And then here are representative images of the cells that were treated with either compound. And these black arrows are there to highlight the open membrane pores, so representing and really demonstrating the decreased number of cells that were able to invade. So we're able then to quantify all of these data, and we found that there was significantly decreased invasion shown following treatment with either compound. So because of our in vitro findings, we proceeded to in vivo experiments. So we injected SKN-BE2 cells into the flank of athymic nude mice. So once the tumors averaged about 70 millimeters cubed, we started treatments. So the animals were randomized, and the control group received the vehicle, and the treatment groups received either 3364 or 8385 with 50 milligrams per kilogram BID orally. And then we measured the tumor volumes at least 3 times per week. And then after 21 days of treatment, the animals were euthanized and the tumors were harvested. So there was a significant decrease in tumor growth following treatment with 8385, as shown with the gray line, and compared to the vehicle group, shown with the black line, as well as there was a down trend in tumor growth with the animals treated with 3364, as shown by the green line. Another way that we can kind of quantify this data is we can look at relative tumor growth, where we examine the ratio of the final volume to the starting volume. So these dots are representative of actual animals, and the yellow bars are there to show the average relative tumor growth among the groups. And so you can see that animals treated with 8385, again shown by the green dots, had significantly decreased relative tumor growth compared to the control animals. So in summary, PP2A is a known tumor suppressor and is downregulated in numerous cancers. And here in these studies, we have demonstrated that these novel 2 PP2A activators effectively decrease a malignant phenotype in long-term passage cell lines, a patient-derived xenograft, as well as in vivo. So these findings support the further and continued investigation of these novel therapeutic compounds so they can advance, hopefully, into the clinical arena to better serve a patient population that's in dire need for innovative therapies. So I'd like to thank my mentor, Dr. Elizabeth Byerly, and all the brilliant members of the Byerly Lab, Department of Surgery, Division of Pediatric Surgery, our collaborator in funding. And I'm happy to take any questions or comments at this time. Thank you.
Hi, thanks. Great talk. Lindsay Talbot from St. Jude.
Yeah.
Just wondering, since you have the mouse data, did you see a survival benefit? Because with a differentiating tumor growth may not be your best metric. Thanks.
Right. Yeah. Yes, ma'am. So I guess the reason that we decided to end the experiment at the 21 days is that, and those are undergoing studies, we of course have harvested the tumors and blocked them and are hoping to do IHC to potentially look at different mechanisms with different stains, Ki-67 as well, obviously proliferation. So, in order to kind of analyze that, if you let the treatment groups, of course, grow to the point where they would need to be euthanized based on the size, it might be harder to kind of capture that potential mechanism we could see on IHC staining.
I had a couple questions as well. I was curious, how did you determine the dose to use in your in vivo study? Because it seemed like in vitro there was pretty dose-dependent effects.
Right.
And then the other thing I was curious about is, have you done any work looking at what changes may be going on in the signaling pathways that are driving these differences in phenotype in terms of tumor growth, proliferation, motility?
Yeah, yes, sir. Thank you for your question. So for your first question, the reason that we used the 50 milligrams twice a day is that the collaborator who helps us with these compounds and develops them has looked at these in glioblastoma as well as actually Alzheimer's disease is kind of how they initially got started. And those were the safe doses that they found to be used in their animal experiments. And so we kind of our first run also did kind of a toxicity study where we made sure that our animals, our athymic nude mice, were going to be able to tolerate it and no changes in weights, et cetera. So they were able to tolerate it. So it was really just based on the prior studies from our collaborator. And then your second question, yes, we have been looking obviously at mechanism, and it does seem to be cell line and drug dependent. It's, for example, like the BE cells, we see more of potentially an ERK kind of MAPK pathway manipulation, which is a known kind of downstream of PP2A that others have shown. As well as apoptotic for the Shep and WAC is an isogenic cell line. Those are obviously relatively similar, obviously, except for the MYC amplification with WAC. But we've seen that there's a potential increase in apoptosis with those, with an increasingly PARP, like previous presenters talked about, and things like that. So I think it's maybe not necessarily one actual mechanism per. I think it's, which of course is cancer for you, but definitely kind of multifaceted.
It's never as simple as we want it to be, is it?
That'd be too convenient. Yeah, absolutely.
Well, fabulous work.
Thank y'all.
Our last presentation is going to be by Dr. James Moon from Mount Sinai Hospital, entitled Best Safe Resection for Pediatric Neuroblastoma.
Good morning. Thank you for giving me this opportunity to talk today. My name is James Moon. I'm a general surgery resident at Mount Sinai, completing my research fellowship at the Children's Hospital of Philadelphia. Today, I'll be presenting our work on the best safe resection for pediatric neuroblastomas. Surgical resection of neuroblastomas remains a challenge as tumors can be widespread and abutting vital structures. Thus, we have implemented a best safe resection approach by trading off excessively aggressive resection for maximal debulking with safe margins to mitigate the surgical morbidity and mortality. We reviewed records of all children undergoing surgical resection at our institution between 2002 and 2020, collecting demographic, preoperative, intraoperative, postoperative, and survival details in a retrospective manner. We compared the group that underwent gross total resection, defined as greater than 98% tumor resection, versus the partial resection group, defined as less than 90% of gross total resection. A total of 217 cases were identified, with 162 cases in the complete resection group and 55 patients in the partial resection group. The demographic data were equivalent between the two groups with equal distribution male to female, predominantly white race, and an average of 3.8 years of age and 17 kilograms of weight at the time of resection. Looking at the primary site of the tumors, predominantly adrenal tumors were the majority of the cases, with 55% of complete resection groups being adrenal primaries versus 34% of partial resections being adrenal primaries. There was a statistically significant increase in thoracic cases in the partial resection group, as 20% of those in the partial resection group were thoracic cases versus the 5% of cases in the complete resection group. Partial resections were often more technically challenging cases, evidenced by longer operative time, by approximately 45 minutes, a higher rate of vessel injury of about 6.6%, a 8.5% higher rate of hemorrhage, and a significantly higher rate at 26% increased need for intraoperative transfusions. Additionally, estimated blood loss was also higher in the partial resection group by 118 cc's. Postoperatively, the length of stay for the partial resection group was higher by 1.3 days, and the partial resection group was twice as likely to need postoperative ICU stay after surgery. Nonetheless, there was no significant difference in both the short-term and long-term complications between the two groups. And the 5-year survival data was equivalent between the two groups at 75% or 79% survival at 5 years for the complete resection group versus 70% for the partial resection group. Thus, in conclusion, the best safe resection approach to debulking technically difficult tumors in the neuroblastoma surgery provides equivalent post-surgical outcomes while potentially reducing the morbidity and mortality associated with excessive tumor resections. Thank you for your time. I'll take any questions at this time.
You're going to hear two comments. Daniel and I, we've been taking care of neuroblastoma for 30 years clinically. And when we started, of course, we did these enormous operations. Probably now with the evolution of chemotherapy, the evolution of bone marrow transplant, the evolution of immunotherapies, and as you've heard today and you heard yesterday, the evolution of repurposing of other FDA-approved drugs. There is one thing about your data. There are some sites of neuroblastoma that have biologic inherent benefits. Neck, pelvis, thoracic. They do better than those very big adrenals. Were you able to parse out if you looked at those two groups separately to see if your conclusion was still valid?
Yeah, so thank you for your question. And I think that's definitely the evolution that the field has taken in the past decade or more with, as you said, the advances in the basic science arena with the treatments. Unfortunately, if we subdivided the groups even further, our numbers were not enough to really see significant differences or actually have the power to actually see if there would be any significant differences by further narrowing the subgroups.
Dan Malone, Cincinnati. And maybe related to that last comment, you know, the COG-A3973 study showed an increase in event-free survival with a greater than 90% resection. And the European neuroblastoma study group showed an increase in overall survival with a greater than 90% resection. So I wonder how you explain that discrepancy between your results and those results, and could it be either selection bias, if you could comment on that, or is it a numbers issue? And you know, the A3973 study did not have the power, I don't think, to show an improvement in overall survival, but the European study was a significantly larger study, and it's the only one that's really showed in a prospective study an improvement in overall survival.
Thank you for the comments. I think one of the areas that's inherently difficult in this field is the actual quantification of the degree of resection. I think as surgeons, there's certainly a degree of overestimation from each surgeon to the exact degree of resection, and that's why it can be a little difficult to actually compare across studies the exact number at 90% versus 95% versus 98% resection. And thus, multi-institutional studies, I think, would be valuable in giving us more enlightenment in that area.
Krista Grant from New York. Nice paper. I was very surprised about your findings with the thoracic neuroblastoma, that only 20% were fully resected. Can you comment on what percent were approached open versus thoracoscopically? And also in your data, I didn't notice any mention of image-defined risk factors. How did that play into your findings?
Yeah, thank you for the question. To address the first question, I do not have the exact numbers right now in terms of thoracoscopic versus open surgeries for the thoracic cases. I can definitely look into that and get back to you. In terms of the INRG findings, I think with the implementation of the new guidelines in 2009, they are definitely more of an area that is focused on these days for staging purposes. However, our study reaches back to as early as 2002, and the data wasn't quite there to quite get us the retrospective INRG staging for the cases that were earlier on.
Howler from University of Wisconsin-Madison. Got two questions. Number one, how you define partial versus more complete resection? Do you have any evidence of imaging post-op to show that? And number two is your data show that there's more complication in a partial resection. And I wondered, is it intention that when you come in, you say we're going to do a partial resection, or because a complication happened, then you end up with a more incomplete resection?
Thank you for the questions. To address the first question of the quantification and the imaging findings, it is definitely an area where it is hard to get an exact numerical value of the resection. And postoperative imaging can be a little variable to be used in terms of identifying exactly how much resection there was, comparing pre-op and postoperatively. Additionally, our group has found that postoperative imaging, there's been some issues with correlation with the degree of resection that the surgeon has felt that they achieved because of either postoperative edema or rapid growth after surgery, that the group felt that it wasn't necessarily a correlate that you could use accurately to address the amount of tissue that you had resected. Secondly, sorry, could you repeat the second part of the question again?
The second question is whether the complication caused the incomplete resection.
Right. So to that issue, unfortunately, I don't have that data. I think everybody that goes into a difficult case goes in with the mindset, at least in our group, with this best safe resection approach. I think with difficult tumors, the idea is that you would debulk as much as possible safely. Obviously, as surgeons, we try to do the most that we can, but I think it takes a certain mindset and humility to be able to realize what is safest for the patient at the time of surgery.
Great. Thank you so much.
Thank you.
I want to thank all the presenters for their hard work and the audience for your participation for a wonderful session. Thank you.